Good afternoon, everyone. My name is Glenn Keeling. I'm the administrator for HipecTreatment.com. I'd like to welcome you to today's Hipec webinar with Dr. Jesus Esquivel of Beebe Healthcare in Luz, Delaware. The title of our webinar today is Current Status of Laparoscopic Cytoreduction in Hipec. And before we get started, I'd like to introduce Dr. Esquivel. And if Dr. Esquivel could tell us a little bit about his Hipec program at Beebe and how long they've been offering Hipec. Dr. Esquivel?
Thank you very much, Mr. Keeling. Nice to be here with this audience today. It is always a pleasure. I have been around doing Hipec for quite a while, as many of you may know. And I joined about 3.5 months ago, Dr. Jim Spellman here at Beebe Healthcare. He started a Hipec program about 12 or 14 years ago. And it's been an honor and a privilege to work with such an experienced surgeon. And I look forward to answering any questions that you may have regarding this topic of a laparoscopic cytoreduction and Hipec, or any question in general related to Hipec and peritoneal surface malignancies. Thank you very much, Mr. Keeling.
Okay, we have a question coming in. When was the first laparoscopic cytoreduction for Hipec done?
Oh, great question. Let's see. The first actual procedure was done by Dr. Andrew Aberbach and myself in 2009. So 12 years ago, and it got published in February of 2010, and it was for a patient with peritoneal mesothelioma. So that would be, 11 years ago, basically.
Okay. Dr. Esquivel, what patients are candidates for laparoscopic Hipec rather than just the laparotomy, which is normally done in Hipec?
Okay, I think the ideal patient would be somebody that has a very small burden of disease. You know, we frequently use the PCI, the Peritoneal Cancer Index. And as many of you know, it goes from 0 to 39. Our original publication, we picked up a number of 10. So that would be what we call the low volume of peritoneal disease. And ideally, it will be also from a low level of aggressiveness tumor. So a patient with pseudomyxoma peritoneal with a PCI of 10 or less would be the ideal candidate, in my opinion.
Okay. Is there a role for laparoscopic Hipec in treating ovarian cancer?
I think the role would be if you have a patient that has had a very good response to systemic therapy, and again, now the peritoneal cancer index is 10 or less, I think those patients can be treated via the laparoscopic route. Ovarian cancer is a little bit more difficult because the recurrence rate is quite high, whether you do it open or laparoscopically. So the debate still is centered about when to do the initial Hipec and how aggressive or extensive that procedure needs to be. But I think that the role of a laparoscopy is growing more and more in every field, and peritoneal surface malignancies should not be excluded.
Okay, here's a question coming in now. What are the 3 places that cannot be discovered by laparoscopic, as some Hipec doctors have said it's impossible to reach? In other words, are there limitations of laparoscopic Hipec in the cytoreductive process itself?
Yes, so that's a very good question, and that question has been, in my very humble personal opinion, one of the reasons why laparoscopic cytoreduction and Hipec has not taken off as much as I would like it to see it. That has been an argument for some of my senior colleagues that you cannot see, but let me remind you that there is not any single intra-abdominal malignancy that is not being treated via the laparoscopic route. The traditional spots are that you cannot see well behind the liver, but I don't believe that. Let's just put it that way. First of all, peritoneal dissemination is not a random event. We know that some of those patients, the number one place that you have to look for is the small intestine, because those are the areas that are going to get these patients into trouble. And the small intestine, even though the ligament of Treitz, which is another area that is frequently quoted as not being able to see, it's very accessible nowadays. We have learned a lot. Laparoscopic gastric bypass surgery has allowed us to become very familiar with those areas. And whenever I do a laparoscopic cytoreduction, I always team up with a bariatric surgeon, which are very familiar with those areas. So I don't think that there are any real hidden places in the abdomen, number one. And number two, again, it would be extremely unlikely to have a significant amount of disease in other of the more common areas and not being able to see it in those areas that are hidden, either on an MRI or a CT scan.
Okay, question coming in from our audience. This patient had surgery in June. She's still in a lot of pain on the right side under the rib cage. Is this to be expected, and what should she do?
Well, I don't know the extent of the operation that this particular patient had, but the right hemidiaphragm is a frequently involved area. And when we do an open procedure, we put a retractor that puts a lot of pressure in that particular area. So this is a very common complaint. My recommendation would be to two things. One, to walk a lot, and two, to take, if the patient can take Advil, Motrin, which is an anti-inflammatory more than a narcotic. Of course, we are always concerned. Pulmonary embolism can present in that way. So if there's any question of the patient having pain that doesn't go away, or any signs or symptoms of shortness of breath, the best thing would be to seek out medical attention.
Okay. What are the advantages of doing a laparoscopic Hipec?
Oh, that's one of my favorite questions. So the more we learn about cancer and cancer behavior, we know that anything that we do to the body can contribute, to the growth of cancer. We know that whenever you have a big incision, you have to heal that incision, and the body releases a lot of very nutritious proteins. We call them healing factors, and cancer is very clever at taking those growth factors and benefiting from that. So that's number one. Number two, we know that the more of an insult that we do to the body, the more immunosuppression is generated. So we know that when you're immunosuppressed, there's an opportunity for any tumor that have been left behind, tumor that you either see or do not see, has a bigger chance to come back or to grow. We also know that the recovery from laparoscopic surgery is a lot faster than when you have a big incision that is associated not only in the immediate postoperative period with more pain and longer hospitalization, but in the long term, there's a bigger chance of having an abdominal wall hernia that will require another intervention, and also is a much higher incidence of adhesions that can contribute to bowel obstructions that may need another surgery.
Okay, another comment from the patient that had pain under the rib cage. She did have a complete hysterectomy, and she had her gallbladder removed. Would that change your answer?
No, sometimes when you remove the gallbladder, there can be complications of removing the gallbladder, and that can be what we call a bile leak that can irritate the area in that region. So again, I think that the best course of action for that particular patient would be to call the surgeon and be evaluated based on any other associated signs or symptoms.
Doing a laparoscopic Hipec, are complications reduced?
As we know, the complication rate is directly related to the amount of surgery that is done. So if you were to ask me, is the complication rate for the same amount of PCI done open or laparoscopic, the complication rate will be smaller if you do it laparoscopically because you don't have the big incision. You get to move faster. And remember, the number one and most feared complication of cytoreduction and Hipec would be deep vein thrombosis with a pulmonary embolism. So, if you compare the same amount of surgery, then the laparoscopic route will be associated with less complications.
Okay, along the same lines here, as far as complications, what about hospital stay and recovery comparison to laparoscopy or open?
As I mentioned before, without a doubt, this is not just in peritoneal surface malignancies, but in every single procedure. The perfect example would be if you have an open cholecystectomy, you usually spend at least 1 or 2 days in the hospital. If you have a laparoscopic cholecystectomy, it's an outpatient procedure.
Okay. Are there any particular cases where you start out as a laparoscopic case and you end up in an open case?
Yes. So when we describe the original protocol, because let me remind everybody, we didn't develop a technique, right? It was just a different route because every procedure was being done laparoscopically. So whenever we started this protocol, we picked up the peritoneal cancer index of 10. So that would be the criteria to convert from a laparoscopic to an open procedure. We also learned that when you do laparoscopy, everything is magnified by a factor of 16, depending on which instruments you use. And we did learn that sometimes we were looking at peritoneal mucinous deposits that look very hard to get via the laparoscopic route. And so we opened some of those patients just to find out that there were very minimal implants. The original patient that we were trying to do this also had a very large omentum. So having a patient with a very high BMI, meaning a significant amount of weight, can make an omentectomy much more complicated via the laparoscopic route.
Okay. Generally speaking, the laparoscopic patients, they've been operated on prior to the laparoscopic procedure. In other words, is this their first surgery for treating the disease?
It can be either way. Initially, we would consider someone with a significant amount of previous surgery, basically somebody that had a big midline incision with a bowel resection. We would not consider those patients, but as time has gone by, we do procedures in patients via the laparoscopic route that had numerous open procedures. So again, everything is a learning curve, feeling comfortable with doing laparoscopic procedures, but always keeping in mind that safety comes first. And if we have trouble accessing the abdomen, of course, we're never going to pursue just to keep saying, oh, we got to do this laparoscopically. No.
Okay. And what are the disadvantages of laparoscopic cytoreduction?
I think that the disadvantage is that we haven't done or promoted this particular technique enough to be able to convince a significant number of opponents on the medical field. Let's put it that way. I don't think that there is any given disadvantage of doing it via the laparoscopic route if it can be done. Again, because more and more, every single procedure, even the peritonectomy, we learn a lot by teaming up with the general surgeons that do hernias, in which you have to dissect the peritoneum. So I think that the only disadvantage is that not enough time has gone by. I remember that it was probably 3 or 4 years ago that I had to debate my mentor, Dr. Sugarbaker, in Germany, with the question was that, is there a role for laparoscopic cytoreduction or not? And before our presentation, 80% of the audience said that there was no role. But after the presentation, I was able to change that number to 76% saying that there was a role. So I think, we have published our combined experience with other centers with more than 200 patients. And I think like Dr. Arjona Sanchez from Spain frequently quotes me. I said laparoscopic cytoreduction is here to stay.
Okay, in terms of chemotherapy, is the chemotherapy dosage the same in a laparoscopic case as it would be in a regular cytoreduction in Hipec? Or are the treatments different when it comes to chemotherapy before and after?
No, nothing changes. The treatments before, during, or after surgery remain the same. The dose of chemotherapy is just whatever you were going to do, whether it was on the drug, whether you were going to do it open or closed. And one thing that we have seen is that, of course, we like the closed method to deliver the heated chemotherapy. And so when you do a laparoscopic Hipec, it takes less time because you already have the abdomen closed, basically. But remember, it is the same operation with the same indications, just with a different route.
Okay. Question coming in from the audience. How much can you trust the CT and MRI scans in detecting mucin, in your opinion?
So I think that the CT scan is a very good test for detecting any kind of mucinous deposits. But having said that, it's been more than a decade since we have been pushing to do a peritoneal metastasis protocol MRI. Dr. Robert Barone and Dr. Lowe from San Diego, California, had been advocating this for 2 decades probably. And I think that a peritoneal metastasis protocol MRI is incredibly sensitive to detect mucin, not only to detect it, but also to characterize it. Just very briefly, we have defined that in collaboration with Dr. Ivan Siegelman from the University of Pennsylvania. And we have 3 types of mucin. Mucin 1 would be that just the jelly, just floating jelly that is very difficult to see on the small bowel. Type 2 mucin would be a little more nodular deposits. And type 3 mucin is the mucin that we don't want to see, which is the calcified mucin causing a bowel obstruction. The second generation of this protocol is on the works, and I am very confident that combining a peritoneal metastasis protocol MRI will facilitate the implementation of laparoscopic cytoreduction and Hipec.
Okay. What would you recommend as far as a patient preparing to go through cytoreduction surgery and Hipec from a laparoscopic standpoint?
I think that the recommendation is the same. First of all, of course, you have to be knowledgeable about your disease. There is no question about that. Patients that take charge of their disease tend to do better. Number 2, I always and strongly encourage patients to get second opinions. Our obligation is to the patient. And if any particular doctor doesn't want you to get a second opinion, In my opinion, that is the number one indication to get a second opinion. Now, in terms of what to do to prepare for having the actual procedure, I think that is the same whether you do it open or closed. Stay active, walk, and if you have a significant burden of disease, my advice is to eat small, frequent portions of food to facilitate the digestion. But walking and deep breathing is the best preparation for any operation.
Okay, question coming in from the audience. This person had Hipec done in the UK, 38-year-old male. Unfortunately, the cancer's come back. Can this surgery be done again? Can Hipec be done again?
So, just as the rule of thumb that we use, that would depend on, of course, what the diagnosis is, but the two things that we take into consideration are where is the disease? Sometimes where the tumors come back, they come back in areas that are difficult to deal with, and that would be mainly the small intestine. And another very important thing to consider is how soon after the Hipec. So we don't like to do repeat Hipecs in patients whose tumor came back within 6 to 9 months after having had the original operation, unless this was done by someone that doesn't have a lot of experience, although that is getting a much more difficult situation to find. Our biggest problem in cancer care is not usually the surgery or the Hipec, but rather fighting the biological aggressiveness of any given tumor. So depends on how much tumor, if there's more tumor than the original surgery, or if the tumor came back shortly after having an operation, those will be stop signs to proceed with another Hipec.
Okay. Dr. Esquivel, it doesn't look like we have any more questions coming in from our audience at this point in time. In closing, what would you like to address as far as Hipec, laparoscopic Hipec is concerned?
I think I would take opportunity to leave people with two messages. Number one, if you have ovarian cancer, I think we have reached the point that your doctor will have to tell you why Hipec is not indicated. I'm not saying just laparoscopically. I think that the topic of Hipec needs to be discussed in every patient with ovarian cancer. And the second message would be, if you're going to have Hipec, to ask your particular surgeon whether you are a candidate or not to have it via the laparoscopic route. If they say no, then you should say why not, because there's always somebody out there nowadays that will be able to make an evaluation to determine whether you're a candidate or not. So always keep in mind that our obligation is to the patient, and I strongly encourage patients to get a second or even a third opinion. Thank you very much for your attention.
Dr. Esquivel, thank you very much for doing our Hipec webinar today. And for those of you that would like to contact Dr. Esquivel, visit hipectreatment.com, the state of Delaware, and you'll see Dr. Esquivel's profile. You can request a Hipec consultation if you wish. Dr. Esquivel, thank you, and thank you everybody for attending. Have a good day.
Thank you very much to the audience, and thank you, Mr. Keeling. Take care. Bye-bye.